Live from Borges Medical Center in Kalamazoo, Michigan, this is an internet webcast demonstration of an endovascular coil embolization procedure. This procedure is a revolutionary surgical treatment for brain aneurysms. Today, neurointerventionalist Dr. Firas Al-Ali of Neurosurgery of Kalamazoo will be performing the procedure.
The technique we use in this specialty is predominantly inside the blood vessels. So since we have to go from the blood vessels, we try to go from the groin. It's easy vessels to control. And we have to thread the catheter and wire to get all the way to the blood vessels inside the brain. So what we need to use is different catheter and wire to get us to where the lesion is.
Dr. Richard Durenberger with Neurosurgery of Kalamazoo and emergency medicine physician Rashmi Katari of the Borges Research Institute will provide commentary and answer your email questions throughout the webcast.
Theoretically, anyone can have an aneurysm. It's thought to be primarily a congenital abnormality, and so you may be walking around with an aneurysm and not know it. Now, certain people are at increased risk. Young women that are pregnant, for some reason, are at increased risk of having an aneurysm and an aneurysm that may rupture. Also, people with polycystic kidney disease are also at risk of having it. And probably the strongest risk factor is if you have a family history of having subarachnoid hemorrhages or aneurysms, then you're at significantly higher risk of having one yourself.
During coil embolization, tiny, soft platinum coils are placed within a bulging brain aneurysm in order to relieve pressure from circulating blood on the walls of the aneurysm and to prevent rupture. The coils are guided to the aneurysm through the use of a catheter inserted into the femoral artery at the groin. Through the use of precision radiologic monitors and 3D imaging, the coils are advanced to the aneurysm.
This is a really exciting time to be doing stroke research and treating patients with subarachnoid hemorrhages. The reason being is that we've made a lot of new advances in the last few years. Better ways of imaging aneurysms, such as MRI, MRA, and better ways of treating it that are much safer than the old classic way of doing it. We can either do surgical clips or we can do a coiling, where you actually pass the wire up into the brain and it coils into the aneurysm, and you don't really need to have brain surgery. It's really all done through a simple puncture in the skin.
You can send your email questions by clicking on the button below. Today's webcast will be made available for continuing medical education credit to qualified physicians. And now your hosts, Dr. Richard Durenberger and Dr. Rashmi Katari.
Hi, my name is Dr. Rashmi Katari. I'm an emergency physician at the Borges Medical Center, and I'm here with my colleague, Dr. Richard Durenberger, who's a neurosurgeon here at Borges Medical Center as well. And what we're going to talk about is minimally invasive treatment of cerebral or brain aneurysms. And I guess one of the first questions we really have is, what is an aneurysm?
On the diagram, you'll see a picture of an aneurysm, which is a weakened spot on the side of the blood vessel. We don't think people are actually born with aneurysms, but there's a lot to suggest that people are actually born with a weak spot in the blood vessel that then, as you become adult, sort of like a balloon on an old car tire, causes the side of the blood vessel to weaken and bulge out of place. In this diagram, the blood vessel going from left to right is the parent or the main blood vessel, and all forms of treatment, as you'll see, have to preserve the blood flow through this main blood vessel, but yet stop the blood from going into the aneurysm. The risk of the aneurysm is the very top of the aneurysm is a weak spot, and from that weak spot, the aneurysm can burst, and when that happens, it causes catastrophic bleeding inside of the brain. The whole goal of the treatment, whether surgery or the treatment that you're going to see today, is to seal off the aneurysm and prevent blood from flowing through the aneurysm, yet preserve blood going through the parent blood vessel. Once that's accomplished, then there is no further risk from the aneurysm.
What we're going to see today is Dr. Al-Ali, our neurointerventionalist here at Borges, do a coiling. And we have an animation here that will show a diagram of exactly what he's going to be doing. Again, you see the blood vessel in the aneurysm, and what you see is a guide wire that is kind of introduced into the blood vessel and up into the aneurysm. Once they know they're in the aneurysm, then they push forward a catheter into the aneurysm as well, and that's the blue tube that you can see being pushed up right about now, and you can see it being introduced into the aneurysm itself. What they'll then do is they'll remove the guide wire. And you can see it coming out of the aneurysm as we speak. And then they'll start passing the coil back into the aneurysm. And you can see it coiling into the aneurysm itself, and they'll try to completely fill that aneurysm. And sometimes that will be done with one coil, sometimes 2 or 3. And what they do is they use a coil pusher that then has an electrical charge that heats up and detaches the coil into the aneurysm. So the coil is actually left in the aneurysm, and you can see the detacher come back out again. Now, they need to put in more coils. They can do that. And the goal, again, is to completely fill the aneurysm with this coil. What happens then is they're, again, able to detach it and remove the catheter. And then over time, the body itself will start forming thrombosis or a clot in that aneurysm. You can see that occurring. That occurs within 5 minutes of the coil being placed in there, and it takes about 3 months before that's completely kind of sealed off. Richard, before this new technique, I mean, 5 years ago, what would you have done for an aneurysm like this?
The treatment of the aneurysm prior to the coiling was a mature surgical operation that had been done for many years, and the results of the surgery is quite successful and the risk is low. The main goal of the surgery was under an anesthetic, the skull was opened and a small metal spring-loaded clip was snapped across the neck of the aneurysm, and that accomplished the goal of sealing the aneurysm so that no blood could flow through it. It is a good procedure, but the downside of the procedure, it does involve a major brain surgery. The goal of this procedure accomplishes the sealing of the aneurysm, but avoids the intracranial operation.
And do you know how this patient presented to his primary care physician?
The patient we're going to see today is a 51-year-old gentleman who presented to his primary care physician complaining of dizziness and headaches. When his primary care physician examined him, he found that the blood vessels on the side of his neck were creating a whistling noise, which can be a sign of blockage of the arteries. This resulted in testing being done. Ultimately, he had an MRI of his brain and an MRI angiogram of the blood vessels, which revealed the presence of the aneurysm. In this case, the aneurysm was an incidental finding, which means that the aneurysm itself was not the cause of his dizziness, probably not the cause of his headaches, or the noise his blood vessels were making. But now that the aneurysm has identified it, we have the opportunity to offer the patient a treatment for this aneurysm which will be effective in preventing him from the risk or keeping him from having the risk of having this aneurysm burst.
Let's see if we can go to the operating room now if Dr. Al-Ali is ready.
No. Rashmi?
Yes.
I am preparing the balloon. How about if you tell the patients now or who are listening what kind of indication we may have to whose patient are we going to treat? Is everybody with any aneurysm should be treated, or certain people need to be considered treatment more than other people? Richard, can you comment on that?
The two kinds of people that we'll see with aneurysms are those for whom the aneurysm has already ruptured. In those people, treatment of the aneurysm is not an option. The aneurysm has already leaked, and there must be something done to treat it. Before the advent of coiling, that meant you had to have an operation to treat it. The coiling can be used in this circumstance to treat an aneurysm that has already started leaking, and probably at this point, year 2003 in the United States of America, most aneurysms are being treated after they rupture with the coiling procedures. There are still indications with an acute ruptured aneurysm where coiling of the procedure can't be done, and there's still an indication for a surgical procedure to do this. The second group of patients for which our patient lies are those who the aneurysm has been detected before it's ruptured. In those cases, there still is an option of whether to not do surgery or coiling, but at this point in time, the majority of patients with the asymptomatic or non-ruptured aneurysms are being treated with the coiling. The decision whether or not to coil an aneurysm once it's been found is a careful decision. It needs to be made in conjunction with the patient's physician, the surgeon, and the physician who does the intervention, like Dr. Al-Ali. This is in most places done as a collaborative decision involving all the different specialties to be sure the most appropriate treatment is offered.
You know, Richard, you said that this patient is really an asymptomatic. I mean, he came in for one complaint and was found to have an aneurysm. What do, you know, the majority of these patients present like, either before it's ruptured or if it's rupturing?
The danger of the aneurysm before it ruptured, so to speak, is they rarely cause any symptoms, so that it's there's no, in most cases, warning that you have an aneurysm until it actually leaks. In this man who had his testing done for an unrelated condition, it's very fortunate for him that his aneurysm was detected before it leaked, and now he has the opportunity to treat it before it bleeds.
And how do they present when they do rupture?
Presentation of the aneurysm when it ruptures is most often a catastrophic event. The symptoms can range anywhere from a sudden, severe, what we call thunderclap headache, often coming on when the patient's straining or bearing down, to the extreme other end where patients actually expire from the rupture of the aneurysm almost instantaneously. And then there's those patients in between who present with various degrees of headache and symptoms of brain problems because of the bleeding inside of the brain. It is a catastrophic event and is certainly a kind of thing that if we can treat this and offer treatment before the aneurysm ruptures, it's a much better way to handle this disease than having to wait till after the aneurysm ruptures. It's been estimated that maybe 1 in 4 or 1 in 3 patients with an aneurysm that ruptures don't even survive long enough to get to the hospital, and those that do make it to the hospital, in spite of the best treatments, are often left with damage to their brain. So the aneurysm is very small, but it's a potentially very devastating lesion, and with the advent of these kind of procedures and imaging procedures that can detect aneurysms before they rupture, there's really an opportunity here to make a difference in treating these aneurysms before they break.
Change your clouds.
You know, again, it sounds like the goal is really to identify these early and, if need to, intervene so they don't rupture. I mean, once it's ruptured, you're kind of behind the 8 ball is what it sounds like. And that's kind of the goal in this patient today. I guess the worry is that this aneurysm may rupture in the future, so rather intervene now to prevent that from happening. Is that?
Yes. And patients will often ask us when an aneurysm is identified, if I don't have it treated, what is the risk of the aneurysm rupturing? Is my risk so high that I should undergo a surgical procedure or a coiling procedure? Or are there some cases when an aneurysm is found that perhaps nothing should be done? And again, this is why we encourage a collaborative discussion among the providers, the pros and cons of different kind of treatments for these lesions. There are certainly cases in people who are elderly or in frail health who have a not particularly risky type of aneurysm that perhaps it is of less risk not to do any kind of treatment than to perform even a coiling or a surgical procedure. So in almost all cases, except those with what's already ruptured, the decision to treat should be a thoughtful, careful decision with the input of all the providers as to what would be the best choice. In any case, to try to determine the risk of rupture of an aneurysm, we're left with statistical models which say if you have an aneurysm of a certain size in a certain location, for example, let's say your aneurysm risk rupture is 1 in 1,000. This certainly gives you an idea of your risk of rupture, but doesn't tell you whether you're the number 1 or you're the other 999. And that's an important decision because some people are uncomfortable and very uneasy living with the idea that there's this potential devastating thing in their head. And in some patients, that is the deciding point for which they make a decision to go on and have treatment.
Okay, guys, I think we're ready here. If you come to the OR. Hello, everybody. I'm Dr. Al-Ali, neurointerventionist here in Borges. With me, Dr. Ackerman. He's a medical student spending some time here. This is Tom Spiegelmeyer. He's the registered tech. And everything cannot be happening if Dr. Droskovich was not here putting the patient to sleep. In the back, we have Sandy Smoker and Kevin Major, who are the tech running the machine for us. And in the room, I have Sue Lewis and Timber. Where are you, Tom? Tom is in the back there, monitoring the patient for us and make it easier in Dr. Droskovich during the procedure. As you know about the patient now, everything. So I'm just going to go ahead with the procedure. We're going to put the micro catheter inside the aneurysm the way you saw it in the model, and the animation model. So this is the micro catheter. You see how small it is if you compare it to my fingertip. And we're going to just pass it through the catheter. And I don't know if you can show where the groin is here. This is where the puncture site in the artery. And this is what the, give me the wire out, please. And this is wire out. And this is what the patient will have at the end. This is the wire which is inside the catheter, and hopefully will drive us into the aneurysm. So for now, we're going to just push the catheter inside the aneurysm through the tube. The tip of this tube now, you see here, is inside the patient, what we call the carotid artery. It's at the base of the skull, very close to the aneurysm. So when I push it here, just going to go through the tube till it gets to the patient, actually just blood vessels. Okay, let's try to push it in. So now it's going in. I'm going to fluoro, and you're going to see it coming up. What you see now is the aneurysm, the outballs to the side, and also you see a small balloon I put just before we go live against the aneurysm neck. I feel sometimes is really very helpful to have it. It's just, this is the wire coming up, as you can see, the tip of the wire there. And now we're going to take the catheter up. I take the 5 for instance, please. Yeah. And now you see the catheter is going up, and just below the aneurysm, I will just flush it, just make sure there's no air going to the patient brain while we're doing this. Wire out, please. And then we're going to hook it to the catheter, to the aneurysm directly. And from then we start coiling. So the coils come in pre-shaped position. They have a specific shape they come with, but they come to us in tube, which is make it very straight tube. I'll show it to you later on. So we hook the straight tube to the straight catheter, and it stays straight, the coil-wise, until it leaves the microcatheter inside the aneurysm. So now I'm just flushing the microcatheter, making sure there's no air.
And that's why you were tapping it, is that correct, Firas?
Yeah, just to pull all the air out. Give me the wire, please, the micro wire. Okay, now let's take the micro wire again. And this is the micro wire. Okay, one second. I'm just going to make a small shape on the top of the wire, as you can see, just to get almost the shape of the vessels going to the aneurysm. 281 is fine.
Do you have to specifically shape it for a specific aneurysm, or is that the kind of thing?
No, it's kind of every aneurysm has its shape, and you can adjust to the tip of the to the shape of the catheter. You shape the wire corresponding to the shape of the aneurysm. It's like almost where you want to go. You know, is it too acute angle? Is it little angle? And things like that. And where we're going to go like this for me is the angle is not very acute, so I'm happy with the tip here I have, and I'm hopefully going to be going very smoothly. And here I see the tip of the catheter. The wire is going to be going out very slowly, very soon. That's why here we are. I don't know if you guys can appreciate now. The wire is outside, and now we're going up. So now we're going to take the catheter up. Okay.
again, what we're looking at here is basically an angiogram, which is or under fluoroscopy, which is kind of a moving X-ray, really. So you can actually see what's happening while you're doing it.
Correct. This is what we call the road map. So you see now I'm trying with my wire. I cannot get to the aneurysm. What I may do, I just maybe take the wire back out and put different shape like we did the first time. Just shape it differently. Okay, Tom, let's take this please out.
We may want to go back to the frontal view again. I think you got a better look at the aneurysm. And
yeah, Rashi, but I'm not taking. I don't care how look you're looking at. I want to see it first.
Oh, okay. I meant on the audience to see it.
Okay.
Interesting technical advance is we're watching a still picture of an angiogram that was taken several minutes ago. The computer is able to keep the contrast in that vessel. In real life, that contrast went through there in just a few seconds. And so the operator does not have to continue injecting contrast. This so-called road map or picture of the blood vessel with dye is superimposed upon the track of the catheter, which cuts down significantly in the amount of the dye that has to be done.
That's absolutely true. Yeah, you can shoot a 3D animation by now. I think it would be a good idea to see what the aneurysm looks like in this gentleman. Are you seeing it right now? So you can see now this is the outpass to the side. Maybe, Richard, you can also fill them in. It's just above what we call the carotid ring. And these aneurysms sometimes when they rupture, they can give an intracranial hemorrhage. But you see also from technical point of view, there is an acute angle we have to go through in order to reach the aneurysm. And Richard, is this an aneurysm which is difficult or easy for your approach in general, or what?
This is an aneurysm that could be clipped surgically.
Yeah. Well, I think this is what the neat things about if you have an aneurysm, I think you should go to a place where they can do both of them. And they can clip it or they can coil it, because they can give you the best what is for you. You don't need to go a place where they do only one. I mean, here we are going to the aneurysm. You see that, the wire now? Here I am inside the aneurysm. You see it? Can you guys see that?
Yeah, we can see it now.
Yeah. Now what I will do, I may just see if the catheter will follow that acute angle. If not, that's one of the time I can use my balloon. It can fix the wire there, and it can sneak my catheter back in. Here I kinked into the aneurysm. This is very good. That gives me very stable positioning with the wire, and the catheter is coming with that acute angle around, and now I am inside the aneurysm. Can you guys appreciate that?
Yes. Yep.
So okay, here I'm pulling my wire out. I'm sitting deep inside the aneurysm. I won't be staying here, but for the time being, I'm going to flush the catheter. I will hook it to a flush, so I want to be deep, and so I don't lose my position. Wire out.
And again, the catheter is just like a hose, basically, correct? So you can pass things through it.
Correct. We're going to have the TUI. So now, I'm going to need like a few minutes just to hook these technical things. Take the, hook it to the flush, because as you know, we are inside the patient's brain, so we have to be flushing continuously. Otherwise, the clot may form and give the patient a stroke. That's one of the complications of this procedure, actually, because we are sitting inside the blood vessel, so we do whatever we can to minimize these stroke kind of episode.
Firas and Richard, one of the questions we got by email was, on this patient, why did we choose coiling over clipping?
I don't know. Richard, I can answer. Do you want to answer, or you need to answer?
Go ahead and give your answer.
Well, okay, my answer is because it's, as we say, this is a non-ruptured aneurysm. And we are talking, as Dr. Dernberger was saying, just statistical odds. What's this aneurysm going to cause this patient a problem? And if we say the risk is 1% per year, that's, if he's 50, he's going to live 30 more years. That's almost 30%, which is we need to do after a surgery, which is relatively non-invasive in order for him to have a good quality of life. in general, I think, this is my take in general, if I can coil the aneurysm and somebody who's healthy and have a good expected quiet life and not very young being not 20s or 30s or early 40s, because I am 40 years old, that tell you why it's young, come down. And when this age, around this age, I offer coiling because I think it's less traumatic and there's less trauma to the brain and in the brain which doesn't have a trauma yet. Thank you. Arthur, Richard, what do you think?
I think the first decision to make in the aneurysm is whether to treat it at all.
Right.
The second decision after you make the decision to treat it is whether to do the coiling and the surgery. In most studies, the risk factors of and the coiling is not without risk, but it is a very low risk procedure, and so is the surgery. And our thinking now is if the surgery and the coiling are both the same risk, which they are, then it seems more appropriate to offer the less invasive procedure or the coiling rather than the surgery.
And this patient also saw one of your partner, Richard, too. I mean, we don't go take a patient out of the street and we offer them either option. If not, we didn't talk to each other, and we give the patients the luxury to see two physicians who can treat the aneurysm. And then we decide as a team more than like somebody's decision, honestly. Okay, I'll take the coil. 5?
Yes, I would reiterate that this is a decision that should be made by both providers, both the surgeon and the interventionalist, to give the best opportunities and best options to the patient.
Give me the coil.
I will remind people to send in their questions by email. You can click on your screen, and we will try answering them during this 1 hour period if we can. The other thing, just a reminder, you can obtain CME credit for this. There's one CME credit that is available. I think that is through Borges.
So Rashmi, sorry to interrupt you. Just going to show the people the coil, how it comes. It comes in this plastic tube. I don't know if you can see it. This is, and compared to that to my finger, is very, very, very small. But the coil is a mass. It has a shape. It comes to us straight like that or straightened into this plastic tube in order for us to be able to deliver it to the aneurysm without, which is bigger than its real size, because now it's just completely straight. You see that? So that's now the tip of this catheter here is inside the aneurysm, and this catheter is inside this catheter. As soon as I push the coil, it will stay straight inside the blue catheter, which is now in the patient aneurysm, till it gets to the aneurysm and exit the catheter. So it will have they take the shape that it have.
For us, one of the email questions was, how long do these coils last in the brain? Do they need to be replaced, or what happens with them?
Well, this one of the reasons they choose platinum, as you were saying in the beginning, Rashmi, is because it's inert, so it doesn't create a chemical reaction. So it can stay for a long time. A lot of people are around with this now for maybe 10 years since we started doing it with, experimentally. For the time being, they're doing very good. Honestly, we need to wait 50 years and find out what's going to happen in 50 years. But now I'm going to push the coil inside the aneurysm. So I'm going to take you back live to the camera, and we're looking to the frontal, and you see the catheter kinked inside the aneurysm, and all of a sudden you're going to see it getting darker. So this is you watch your wire, Tom. Tom, you watch your wire. And now you're going to see the catheter getting darker. And here, see that? The catheter getting darker, and now the coil is coming inside the tip of the catheter, and soon it's going to be exiting the catheter, and here it is. Now we are looping inside the aneurysm. Now and now what we call the coiling. It is coil laying inside the aneurysm. Now we have a loop getting out, so sometimes we push. It's not good enough. This is one of the reasons why I like to have the balloon. It helped me tremendously in these circumstances.
So the balloon's actually in the vessel and stops it from popping out, is that?
Yeah, but I didn't inflate it yet. I don't use it in every single second. I inflate it, I put it sometimes like security measure for me if I need to, if there is acute rupture or something like that, or if the coil doesn't sit in the aneurysm nicely despite multiple attempts. And so now you can see the coil is nicely getting inside the aneurysm. It's coiling actually inside. It has the nice round shape, the way we like it. And now we're going to push the last few millimeters and hoping everything is going to stay in as it is now.
And the concern is if any of it pops out, it occludes the blood vessel that's feeding the rest of the brain. So that's why you want to keep everything inside that aneurysm.
You're exactly right, because that'd be, you know, and if it pop up a little bit, it's okay, to be honest with you, because this coil will be in contact with the blood vessel, with the blood. But we don't want it to be interfering with the bloodstream to the patient, to the patient brain. So that's why we need to be as stable as inside the aneurysm as we can. And now I'm just pushing the last few segments. I mean, we're not talking millimeter, we're talking sub-millimeter now, outside the catheter to make sure the whole coil is inside the aneurysm. And now I think it is. I'm going to do what we call an injection just to show what the aneurysm looks like now before we release the coil, before I detach it, because I do have still 100% control over the coil now. And if I release that coil, I have no more control over it. In other words, if it goes to the patient's brain, it does go to the patient's brain. That's why we pay a lot of attention before we release any coil, and we do multiple pictures sometimes. So here we are. Now you see now the blood vessels all are filling very nicely, and this aneurysm you can see here from the frontal view, the coil is completely outside the blood vessels, which is only inside in the aneurysm, and that's exactly what we like. And now I think we can go ahead and just detach this coil, and the way we do that is by hook the wire. Maybe you can show here. The wire, this is a coil pusher. Now we hook it to these two electrical charge. This is positive, and there's the one which is negative, black by the patient's groin, and we go electrical charge. Okay, let's detach, please. So that electrical current will heat the connection between the coil pusher and the platinum coil very little bit, and that will be enough to disconnect the coil pusher from the coil, and then we pull that out and we put a new coil. It takes 3 millimeters, the longest 3D, 2D, please. So now we have like a minute or so, just dead time, waiting for that coil to detach. If you guys are going to discuss something or show something.
We have another email question. They want to know how long is the patient in the hospital? How long is the recovery? How long before they can go back to work and do their
2D,
regular?
3 millimeter. Yeah. Well, I mean, honestly, let's say when everything is going okay, and which is most of the time of the case, the patients come in the morning, we do the procedure in the morning, and they leave next morning. So it's like 24 hours procedure time, and with the train. So now the machine gave me signal that it detached the coil. We're going to go back on the fluoro, and I will pull out the coil pusher, hoping the coil will stay inside, because sometimes they don't detach. That's one of the reasons we pull the coil pusher extremely slowly, and here I'm pulling it out, but the coil is inside the aneurysm very nicely. So that's first coil in. And now we're going to do a new coil. This guy is slightly smaller than the first one, because we like it to fit inside the first one. So now you have some time too. So as I said, Rashmi, this patient will supposed to leave the hospital tomorrow around noon or early afternoon, because we start late. Dr. Droskovich is a great anesthesiologist, but some people have some headache after anesthesia. They always say, oh yeah, you're blaming us, it's you. Well, I mean, most likely, I don't know what. But, you know, when we put the patient under general anesthesia, we do any simplistic kind of brain surgery. And as one of our colleagues used to say, there's no something as simple surgery. So we always just keep him up just to watch him and see everything okay, and etc.
How long before they can go back to work and do kind of the regular?
Honestly, the day they leave, I tell them just to take it easy and be couch potato. And next morning is up to what they feel. You know, certain people honestly get more tired from being admitted, from general anesthesia, from being and lying down in the hospital. But other than that, they can go back to normal, 24 hours to 48 hours after being discharged from here. So this guy, we can discharge him tomorrow, which is, what's tomorrow, is Wednesday. He can go to normal life in Friday morning. So now here I'm having a new coil coming in. If you are zooming in the frontal view, okay, you're going to see the catheter with its tip inside the aneurysm, and all of a sudden it's going to become darker. And here it is. The coil is coming in, and it's coming in, and now I'm getting inside the aneurysm now. And now here we are putting more and more coil, and I don't know if you can appreciate it, but it is getting in. Can you guys appreciate it over there on the floor, or?
It's kind of hard to see right now. I don't know. Richard,
yes.
Can you see it better?
Yes, you can see the second coil coming in.
Yeah. Do you see that, Rashmi? Something
Yeah.
move? I mean, everything is very gentle because, we're looking, the whole coil mass is 5 millimeters, so the movement is something very subtle.
That was one of the questions they were asking is how big is this aneurysm? You said it was about 5 millimeters?
Yeah, 5 by 5. 5 by 5 millimeters is, fairly spherical, actually.
Another question that was asked is by email, is this the same technique used for congenital aneurysms in neonates, or are their blood vessels too small to really be able to do this kind of procedure?
Actually, you can do that in a neonate too. It's just the neonate, the problem is not the catheter size, it's how much fluid you can give them. In general, we rather wait till they get few weeks old, and it's, as you know, the fluid intake will be significant here. So their heart may not be able to suppress that, to deal with that. But yeah, we use that in a neonate. Now, the second coil is almost completely in. I'm pushing the very last portion of it, which is, to me, is the most stressful one because this is the stiffest portion of it, and sometimes give you a problem right now. So we're very close to be through this. You can see your wire, Tom? Tom?
Yes, everything's fine.
Okay, now I'm just... I think we're safe there. So now we're going to do again another run, take a picture, see what the blood vessel looks like, what our aneurysm looks like, and from there we decide if should we release this coil or should we change it. Or in general, when you put the whole coil in, it's a not good idea to take it out, to fit in, but we will see how that looks. Anyway, here we are. You're going to look to the frontal view, and hopefully you're going to see the aneurysm is filling less. Can you appreciate that the aneurysm is filling less now?
Yes.
Okay, that's something we like too. And now we can just detach that coil the same way we did it the first time, hook it to that electrical charge, and that's going to give us maybe a few minutes or two to chat about whatever. Okay, let's detach, please.
Richard, how are these aneurysms diagnosed? You kind of mentioned this patient had an MRI or an MRA. What are other techniques that can be used
the longest
to
two you have?
identify these?
In the past, patients had to undergo an angiogram procedure to detect an aneurysm, which is a abbreviated X-ray procedure similar to the one that's actually being performed now with the coiling. With the advent of MR angiography, we can now detect aneurysms down to 3 to 4 millimeter sizes, and with the new what's called multi-slice CT scan imaging, we'll probably be able to detect aneurysms even a smaller size than 3 to 4 millimeters. Okay. The advantage of the MRI scan and the CT scanning over the conventional angiography is, since there's no direct entry into the blood vessels, there's no risk of blood vessel damage or stroke when you have an MRI or CT.
Richard, I'm going to take the coil and push it out now, and we are, I think, live in the frontal view. When I pull it out, I want to see all the coils stay inside the aneurysm, and they are. You can see marker at the lower end of the screen at the 6 o'clock going backward, but the coil masses stay stable. This is very good result. This is what we like to see. And here you can take it. And here now we are ready for the third coil, which is going to be again slightly smaller one than the first one, and hopefully will fit inside And I'm really optimistic that this aneurysm will not need so many coils, maybe 3 or 4. That's all what it's going to need, and that will be the end of it.
What's the average number you end up using on these kind of aneurysms, and what's the maximum number of coils you put in?
Well, honestly, like aneurysm is like fracture, if you wish. There's so many kinds of different fracture, and there's so many kinds of different aneurysm, and almost like a people. There's like all kinds of people around here, and I think like the least I did is 1 coil. It's 2 millimeter aneurysm ruptured. I remember the case very well, and I think the most was 18 coil, and as you know, it's going to take longer, and the longer it takes the case, the more dangerous it is. And in general, if you put 18 millimeter coil, that means the aneurysm is big, the neck is big. It's a more dangerous aneurysm to treat.
For us, one of the questions they asked is, once you've had a coil, can you still get an MRI to follow these, or because usually you can't have an MRI if you have metal inside you?
No, actually you can. These are these are MR compatible. It's platinum, so they're inert. They don't move. And actually, I have to tell you something else. One of the other reasons why we use platinum is because it's very radio opaque. We can see it through the patient's skull very easily. That's one of the things that we looked at very carefully which metal they're going to use for that. It has to be something we can see very easily and something that doesn't cause reaction to the patient. Now things change. They want to do more like biologically active coils and things like that, so we get to it later, but these are non-biologically active. And now I'm pushing the 3rd coil. If you look to the frontal view, you're going to see that the catheter's going to become denser. Here it is. You see the coil coming out? And now the coil is becoming very close to the aneurysm. Now we are inside the aneurysm, and we're pushing the 3rd coil in. If you see there's gentle movement over there, and there's some buckling on the coil. You see how it's buckled down there? It's just because there is more resistance now, because the aneurysm is more filled. You can see the coil actually. Can you guys?
Yes.
Well, I mean, Richard, you're a neurosurgeon. You see that every day now. Rashmi, do you think it's visible there?
Yes. Yeah,
okay,
I think
good.
we can see it moving. Even I can see it for us.
No, I mean, Richard is not the guy we're going to ask him. I mean, he saw that hundreds of times. I don't know. So now you can see the last bit of the coil is going out inside the aneurysm, and we're getting very, very close. Here, did you guys see that? This is the last minimum portion of the aneurysm is going on. And the coil is going inside the aneurysm nicely here. And you can, if you watch closely, you can see the tip of the coil, of the catheter, is slightly backed up. Can you see that?
Yeah.
Yeah, and that's because we don't have that much space now. So one of the signs too. So we'll see now. I built some pressure there. Again, before we detach the coil, we're going to do another angiogram to prove to ourselves everything is okay. And this is where I really love having the balloon. I mean, the balloon is like, for the surgeon, the balloon is like the clip they have a problem. They can clip the blood vessels and give them time to recuperate what's going on. And the balloon for me helped to do the same. I just kind of occlude the blood vessels, give me time to do things and think about it. So here we're going to check that aneurysm now. This is the run. See now, you can see there is barely any filling of you're going to see the run again. There's barely any filling of the aneurysm anymore. I may try an extra 2-4 ultrasound, very small, short coil, if it will go. If it will go, I think I'll put it in and maybe declare it victory. If it doesn't, I think this aneurysm is going to be clotting very nicely. This patient is under significant dose of heparin. His ACT was 280. So as soon as the heparin will wear off, you imagine his aneurysm will clot more and more. Yeah.
And again, the heparin is to keep their blood so it doesn't clot while you're doing the procedure. But then once you stop it, the idea is that a clot will form around those coils,
yeah,
and then kind of occlude it off and get rid of the shear force of that blood continuously pounding against that weak aneurysm wall.
Right. And actually, the heparin is safe for the patient not to have a stroke, clot from what we're doing. And it's also good for me because it keeps the aneurysm from clotting quickly, because the clot may form a barrier for the coil to go in. so I fill it suboptimally. I like the aneurysm to stay without any clot till the end of the procedure because I can put more and more coil.
And my understanding is this is an FDA-approved procedure now.
Yeah,
this
since
isn't
95.
experimental or research per se.
No, it's approved since 1995. So it's been approved by FDA now for almost 8 years.
And how many different coils are there? What kind of coil are we using here?
Well, I mean, there's a lot of companies making coil. This is GDC coil. This is a Boston Scientific coils. Cordis, which is a big company, have their coils too. Micros has their coils. Cook has their coils, and there's a lot. Microvention have their coils, and there's a lot of company formed around just coil. It's a huge push in that direction to form more and more of them, and everyone have a specific feature to them, and some of time comes for operator selection and their taste and what they are used to and what the aneurysm looks like. Big aneurysm need different aneurysm coil, and certain company are better than in big coil than this aneurysm or something like that. There's a lot of factors. Some of them are significant, some of them are not significant factors to choose a coil type, to be honest with you.
And again, when this patient's done, you don't really have a big incision like you would in a surgery. It's just simply a puncture wound, almost like a big IV or blood draw that they would do. Is that correct?
Yeah, it's perfectly right. We just put a Band-Aid, like the same Band-Aid you have when you have the blood draw. You're saying right. So it's from this perspective, it's really neat. I mean, if you can see this patient when he wake up in an hour or half an hour from now, it's going to be very hard to believe that this guy just had brain surgery.
And again, the area you're working is down in the groin, whereas I guess, Richard, when you're doing surgery, you're really working up on the head itself.
So that's what I say. This is a brain surgery without having brain surgery. I don't know if that makes any sense, but this is the best way I can see it. So now I'm going to put the last coil, or I'll try to put the last coil and see if that will go. The reason I will try to put the last coil even though the aneurysm is not filling, because the more coil you put the first time, the higher chance you have the aneurysm will never come back. Something you have to know, and maybe Richard, you can elaborate on that. When you do a clipping and you treat the aneurysm successfully, the aneurysm is gone. You never think about it one more time. If you do this way, we're doing it right now, you have to bring the patient back 6 months down the road and do another simple and quick angiogram to make sure the aneurysm is not coming back. And I would say between 6 to 8% of the people you treat by coiling, they will need more, one or more 2 coils later on. So that's an advantage if you wish for. I think we're backing up here. No, we're backing up here. Well, one of the advantages for classic surgery, if you wish, because it's as soon as you treat it, it's just done deal. Okay, you go. Does that make sense?
Yes.
And if the aneurysm reoccurs after you coil them, can you go back in and still do a clipping?
Yeah. Clipping, I don't know. I'll let Richard say that, but if it's, I can go most of the time and add 1 or 2 more coils.
And there is some cases involve doing both procedures.
Yes, of course.
Some procedures cannot be clipped or partially clipped surgically, and then can be handled with coiling. And some aneurysms can't be coiled, end up having to have the surgery to take care of them. So they're procedures that don't always compete. Sometimes they're done together.
Yeah, and I think this is one of the lucky patients who can have perfectly 2 options. But as Richard said, there are certain aneurysms they can be done almost only in one way. There are certain aneurysms need both ways at the same time, almost like they do section, I do section, and that's why it's very important to go to a place where they have the 2 possibilities to treatment, because you definitely can treat more aneurysm if you have the 2 options. And I'm very happy that I have solid neurosurgeon back me up. If something I cannot, most of the time they can, and I hope they think the same. So now the 4th coil is coming in. As if you can see it, it's buckling up, and I think so far it's going, and hopefully going to go completely in. If not, going to be my last coil. I just can tell from now.
Firas, if you get a chance, we've talked about.
Okay, that's a good time. If you're going to show the PowerPoint, I think that's a perfect time.
Okay, we actually have a slide up right now on the PowerPoint on, we talked a little about who are good candidates for coiling. What are contraindications? Who shouldn't get coiling?
Richard, can you fill in that some?
One of the most difficult problems with coiling is the size of the neck of the aneurysm. As you can see from the procedure, one of the possibilities as you're threading the coil in is the coil can pop back out of the aneurysm. The best aneurysms to treat are those which have a small, narrow neck through which you thread the coil, and the narrow neck then tends to hold the coil in place. One of the people on the web asked the question, what's new, what do we expect in the future? Firas alluded to a different kind of coils. Instead of being inert platinum, there are going to be some biomechanical type of coils that will be used. We're also looking at procedures involving a stent, which is a mesh-like tube that's placed in the artery first, and that will you could then treat an aneurysm with a broad neck so that you could pass the coil through the mesh in the tube, and the coil would hold the the mesh of the stent would hold the coil and keep it from pulling out.
Yeah, Richard, it's not a future anymore. Actually, we do it here already. We did it twice, so it's out there. It's FDA approved. We use it twice, and I use it, as you said, exactly for the aneurysm, which looks really big neck, and it will not hold the coil, so it makes the neck smaller. So there's a lot of things over there. The hydrocoil, which is very different mechanism, it inflates itself, it gets bigger, and these also are out there. There's different way of thinking how you're going to treat aneurysm. The blood going to get into the coil and make it bigger, so you don't need to put as many coil, because with every time you put new coil, there's a risk. As you could tell, it was like, your risk of taking the catheter out of the patient, of the aneurysm, and things like that.
Clearly, there is a neurosurgeon or a neurointerventionalist who had a question for you. Is your preference for the GDC soft coils in this case?
Yeah, here I use actually 3D and soft, GDC 10. And why is that? Just because I think they're very soft, they're floppy, and there is no 5 GDC 18. There's no 5 3D. So that was the first coil in. Richard, I really like it. What do you think?
I think it looks very nice.
Yeah, I think it looks very nice. I'm going to detach that coil, and if we can then take the catheter out safely, I will carry victory. What do you think, Richard? Do you agree with that?
I think you won.
Okay, thank you, sir. So now waiting for we have a couple of minutes. So why I would, Rashmi, coming back to why I use the GDC 10 and soft here, just the GDC 18 cannot get there, and we don't have 5 millimeter GDC 18. We have only 6, the smallest one. And also because I'm very used to them, and it has to do, as we said at the very beginning, operator preferential sometimes is not scientific. It's just you are used to them, and doesn't mean you have to stick to those all your life. You're gonna hopefully evolving and learning new tricks, and maybe get familiar with other coils too.
Very good. Now, again, the coils, they come in different lengths, different sizes, different
shape. And different shape.
Okay.
Yeah, actually, different stiffness is a good point too. Now here, we use 3 different type of coil in this case. The very first one is what we call a GDC 3D, 3-dimensional. Like if you look at my hands here under the camera, it looks like make a basket. It's a 3-dimensional, have 3-dimensional, that's the first one we put, and then I get inside this basket and I put 2 coils, which we call in 2D, that's soft, and then the last one I put it in ultra soft. Ultra soft is a very soft coil, we can push it in, and it's easier to smack between these multiple coils inside there.
For us, we did get an email question on someone who's actually going to get a coiling next week at the Cleveland Clinic. They have a 2-centimeter giant aneurysm, and they said their surgeon didn't feel comfortable doing surgery through the skull for this, and they were wondering what's the success rate for these giant aneurysms?
Well, I think this is a very good question, and the verdict now is not out there because of the stent, the neuroform stent we were talking about. Before having the stent, success rate by surgery or by coiling is not very high, but if they can stabilize it, and in Cleveland Clinic they are in good hands. They have very good people over there. But now with the stent, The stent can occlude or make the neck of the aneurysm smaller. They can jam more coil, and also the stent will direct the flow out of the aneurysm more. So the chances I think they're going to succeed is now higher, but there's no big series showing the stent and giant aneurysm what they do.
And again, when you talk about the mesh or the stent, you can put that through the catheter itself, just like you are passing the coil into the brain. So you don't have to do surgery to put that stent in.
Correct. It's different aneurysm, a different coil, different catheter to take it there, but it is the same. Everything from the puncture of the groin that we saw at the very, very beginning, which is a tiny hole by the patient groin, and when the patient leaves this room, it's going to be just a Band-Aid. So now we're waiting for the last coil. Since we have so much coil now, it always increases the heat and takes more longer to release the last coil. And Dr. Druskovich is getting really, really, really annoyed now. He want to go out of here, and but hopefully that will be the last coil. So we're still waiting now. If you have the PowerPoint now, I think it'd be a good time to show some slides over there, Rajmi.
Okay. Do you have any preference? For us, we have, let me see what we can find here for us. And Richard, actually, are there any email questions we can kind of address?
We actually have several questions. Just a couple of comments. We kind of talked like there's an option of doing surgery or doing coiling, but particularly the advent of the stents in combination with the coil, there are opportunities with the coiling procedure to treat aneurysms that never could be treated before, even with surgery. So not only does this turn out to be a very safe and effective way to treat aneurysms that could have been treated surgically, but there now is a method of treatment of aneurysms which before this could never be treated or were considered inoperable.
So now I'm going to take the last coil out, the last coil pusher. So. No. Okay, now, I'm taking the coil out, the coil pusher out, and the coil is still inside very nicely. I'm very happy with the results, so I'm going to try to take my microcatheter out of the aneurysm. That's always sometimes stressful second for me, but hopefully going to be okay. And here you're going to see it coming out. You can see it, guys, moving there?
Yes.
Okay, we're going to move we're moving very gently. Here it's out. You can take this catheter completely out. And now, since I'm done with that, I'm going to take my balloon out and the wire. So now we have the coil there. We're just going to do our last 2 runs, prove everything is okay, and we call it victory.
For us, I mean, we've talked about all the good things about this. What are the downsides? What are the complications you can have from coiling?
Well, none. That's good. Yeah, you can, of course. I think one thing you can do is you can rupture the aneurysm while you're inside. I mean, it's still. I mean, when I use the word brain surgery, it is still brain surgery. You can rupture the aneurysm, and that's really bad news. And this is one of the reasons why I have the balloon over there. I just want to make sure if something happened like that, I can tamponade out the blood vessels. And so here, that looks very nice. Do you like it, Richard? There?
It's very nice, and
yeah.
I just like to spend a couple minutes. This procedure went very quickly, very smoothly, and one might think this is, well, pretty easy to do. I would just like to go on record as saying this is a very difficult procedure, and Firas, you made it look very easily, and that's a testimonial to your extreme skill and experience in treating these.
Oh, Richard, you're so kind. You know, you're very nice. But I have to also tell you, this is, I mean, we're talking about the aneurysm are not all the same. They're like fracture. This is not the most complex aneurysm. The patient who have that 2 centimeter or more aneurysm going to the Cleveland Clinic, it will take me definitely longer to do it, and I think I will sweat more. But as you say, it's not easy procedure. It's a very steep learning curve. With every case, you learn tricks and something more. But I thank you for what you said.
We'd also like to thank Boston Scientific for their support in this program, and also would like to remind people that you can get more information about this webcast through our website. And last of all, again, don't forget that CME credit is available, and make sure you take advantage of that.
So now I think I'm all done. I'm just going to take the catheter out. I think that's for you guys something relatively boring. If you can watch the welcome too, you can talk about something more interesting for the patient as a whole. I think it would be a good idea too. Okay. If there's any email you guys think we need to address before we close here, or I'll say goodbye to you and give them back to you.
You know what? Let us check if there are a couple more emails we want to hit. One of the questions they asked is, do you need a backup neurosurgeon available all the time during the coiling procedure itself?
Yes, absolutely yes, because I was thinking about the balloon and can't stop bleeding, etc., but there's other things the balloon will not help with, like if the ventricles get bigger, or sometimes the coil go into the blood vessels and I need somebody to come and take them out for me. So of course, yes. And I mean, you don't see, honestly, in 2003, somebody coiling aneurysm in his own in a small corner without a strong neurosurgery backup, strong, not a neurosurgery backup. And in the same talking, I think in 2003, if you're going to go to a place where they operate an aneurysm, you have to have the endovascular option available too.
Okay.
Okay.
Again, just another reminder, through the webpage, you can set up an appointment to get more information about what we're doing here at Borges Hospital and what Dr. Al-Ali is capable of doing as well. Richard, do you have any kind of closing remarks? Or?
I think this is exciting new technology and is only going to get better with time. And I'm seeing that as a surgeon who is not going to be allowed to clip these aneurysms anymore.
Well, I think you're right. It's a real exciting time. I think there's a lot of new advances in diagnosing aneurysms, identifying them before they rupture, and obviously after seeing this today, a lot more new techniques that are safer and effective on treating aneurysms that were treated differently before, or ones like you mentioned couldn't be treated at all. So I think it's a very exciting time, and we appreciate Dr. Ali's expertise and your expertise in taking care of these patients.
Can I say a last word?
Certainly.
Okay, I just want to say, thank you for being here. Thank you for watching out here. And I'd like to thank Dr. Droskovich because he came here out in his free time. And I really appreciate that. As a whole team, Tom, Dr. Ackerman, our second Tom, Sue, and Sandy, and Kevin, everybody is great. And thank you for being with us. Bye-bye.
Okay, again, thank you very much for spending this hour with us. I hope this was educational and informative. Again, if you want more information, you can get it through our website at Borges.com. And I think that is it. Richard, anything else? Or
Thank you.
Thank you very much.
You have just seen a live endovascular coil embolization procedure performed by Dr. Firas Al-Ali and hosted by Drs. Richard Durenberger and Rashmi Katari from Borges Medical Center in Kalamazoo, Michigan. For more information on the endovascular coil embolization procedure or Borges Medical Center, please contact us via the link on this screen or call 269-226-8135 or toll free at 1-800-828-8135. Viewers may also click the button on the player window below.